All right. Cool. All right. Looks like we are live. Welcome, everyone. Super excited for today's part 2 on EDS, POTS, MCAS, Dysautonomia. Joined here with Dr. Renaud and Dr. Rose of MedMatrix, two awesome providers. So for today, guys, none of this is all for educational purposes. None of this is medical advice. Today's theme, Dr. Rose is going to be pretty much leading the discussion, asking most of the questions while I'll be moderating it. We got over 100 people who registered for this, so hoping most everyone can make it. We will be answering questions at the end, so if you want to have a notebook on you while we're doing this, definitely recommend that. We're going to be covering a lot of information, and then if you have questions, just write them down and we can answer them as they come up. So with that said, Dr. Rose, why don't you kick us off with an introduction?
Yeah, thank you both for being here. Thank you for all of our viewers and listeners. I'm super excited to kind of continue this conversation. I had two patients just today who are in various stages of kind of uncovering, I'll say, layers of MCAS, mast cell activation syndrome, and how it's overlapping for them with dysautonomia. So this is very real for a lot of our patients and a lot of other people, obviously, as well. So I thought maybe we would just recap a little bit, and Dr. Renaud can kind of maybe give us an overview of how we view these. I think of them as like a triad of these three groups of conditions and how they're kind of tied together. So we've got mast cell activation syndrome, which we spoke about, I think that was 2 weeks ago. Hypermobility, which under that category, there's Ehlers-Danlos Syndrome, and then dysautonomia, under which we have POTS. So Dr. Renaud, if you want to just talk kind of, again, like kind of big picture before we dive into more specifics, that would be great.
Sure. So to give some definitions for people that might not understand what these are, we addressed this in our last podcast. So mast cell activation syndrome is really a multi-system inflammatory and allergic type phenomenon syndrome, basically where patients can have inflammatory allergic type symptoms in all different parts of the body. POTS is a separate sort of condition, but as Dr. Rose said, they do go together. So POTS stands for Postural Orthostatic Tachycardia syndrome. Sometimes it is known sort of as like a, blood pressure issue, but it really involves a big part of the nervous system, the autonomic nervous system, which regulates your body's function, things that you're not cognizant of, your heartbeat, your breathing, your digestion. So POTS can really play a role in MCAS because if there's autonomic dysfunction in the body, it can trigger part of mast cell activation issues and vice versa. When we talk about EDS, we're really talking about connective tissue disorders. So EDS is a very specific connective tissue issue that is diagnosed really with genetics, but there's a broader term that we often use is hypermobility syndromes. So when we talk about just syndromes of people being bendy, people use that word all the time, and these can be patients that can sort of put their body into different configurations. There's different measurements, physical exam that we use. If you can bend your fingers back a certain way, if you can touch the floor with the palm of your hands, if your knees hyperextend, if your elbows hyperextend. So all these conditions go together really as a triad. And the big question is the reason why, what's driving this. And it's really like a system failure thing that occurs with these types of things being dysregulated. But one of the biggest issues that we talked about when we talked about MCAS was the unifying theme is autonomic dysfunction. So they are not really separate diseases.
Let's define autonomic dysfunction, because we got a lot of people who are non-medical listening. So like, what is autonomic dysfunction?
Sure. So like I said, autonomic. You have your autonomic nervous system. Thanks, Cole. Good point. You have your autonomic nervous system, which is the part of your nervous system that you do not control. It is the part of your nervous system that is not conscious. So things like your heartbeat, your breathing, your digestion. So when we talk about autonomic dysfunction, we're talking about sort of a misfiring in that part of your nervous system, where if something misfires, you could have a drop in your blood pressure or your pulse rate, or you could have like a fainting episode. You could sweat uncontrollably. You could have a temperature dysregulation that's very abrupt. You could have very abrupt GI symptoms. So
okay, so when you say autonomic dysregulation, you pretty much just mean anything that's not normal. Like if your body's doing weird stuff, essentially.
Not necessarily not normal. It's autonomic dysfunction is a dysfunction of this particular part of the nervous system. So, like I said, we're talking about specifically the part of the nervous system that you cannot control on your own. So some of the biggest things are your blood pressure, your pulse, your breathing, your digestion, your heart rate. So we're talking about dysfunction in those areas. That's really what we're talking about. Is there something you could add, Dr. Rose?
Well, I was just going to say, no, I think you're doing great. I mean, I think sometimes people are familiar with like fight or flight response or sympathetic overdrive. Like when we talk about that, that's the autonomic nervous system. So the autonomic nervous system is either in sympathetic, which is, high cortisol, fight or flight, or parasympathetic, which is relaxation, rest, and digest. It's like one or the other. So I think people understand that. And it's, as you've said, it's not something that you can will or control. It just kind of happens. So when you're nervous, you start sweating. You don't decide to start sweating. It just happens.
Yeah. So one of the biggest issues when we see these three syndromes together, and whenever we have a patient that maybe has symptoms of one of these things, it often is really important to do a differential diagnosis and look for the other two things. So if a patient is suspected of having MCAS, okay, do they also have symptoms of POTS? Do they also have symptoms of EDS? Because oftentimes they might not meet the diagnostic criteria, quote unquote, for these issues. They might not meet EDS criteria, but they have some physical exam findings that look like it. So when we see these together, that's where it becomes really important, is really understanding how they go together. And really the best way to think about it is POTS, EDS, and MCAS aren't separate diseases that happen to overlap. They're different expressions of the same core breakdown of the body, which is impaired regulation across the nervous system, the immune system, your vasculature, your connective tissue. So that's kind of a best way I can explain it in layman's terms.
I like that. So this is a question that always comes up for me. It's and I think why it can be difficult maybe to diagnose, sometimes to kind of find the right treatment, is that because they seem to kind of co-occur, and as we've said multiple times, affect multiple parts of the system, of the body, right? So you just said, vascular, immune, nervous system. It doesn't always seem like there's a clear cause. It seems like things kind of started at the same time. Everything's kind of dysregulated simultaneously. In your mind, do you feel like, oh, usually it's MCAS that was at the root, and then these other things came after, or it was that, it was is there one thing that kind of you think is underlying, or is it more they're all kind of at the same, it's all dysregulated kind of at the same level?
I think definitionally, right, as I said, they're not separate diseases that happen to overlap. They're different expressions of the same thing. However, in my clinical experience with patients with MCAS and some severe cases of MCAS, I think that the root core is a dysfunction of the immune system, which is mast cell activation. There's this dysfunction of this innate part of your immune system that is driving nervous system dysregulation, that's driving inflammatory response. So let's say if you have a patient with mast cell issues as a core, and they have inflammation in the body, that inflammation is going to translate, say, into the connective tissues, right? Mm-hmm. So it could make their their bendiness or their hypermobility worse.
Worse, right.
Same thing with an inflammatory response, say in the blood vessels, right? If your blood vessels are inflamed, the receptors in the blood vessels are going to get activated. It can change your blood pressure. It can change your pulse. So I think the root here is inflammation. And what is inflammation coming from? I think that's coming from aberrant mast cell reactivity and this really, really dysregulated immune response. But certainly you could have something like POTS make MCAS worse. That's very possible. And it can reflect back on itself. And I think it does. But I think the root is MCAS.
Okay.
Yeah. But it's really hard to pull them apart for sure, as we've talked about. Yeah.
So how often are you seeing dysautonomia without any trace of MCAS? Ever?
No, not really. Yeah. So I guess it really depends on the patient, but you could look at dysautonomia really from its triggers, right? A lot of common triggers of dysautonomia are like some of the most common ones are viral infections. Like we see a lot of dysautonomia with COVID, Epstein-Barr virus. We see a lot of dysautonomia post-surgery and trauma, like people that get concussions. A lot of women struggle with dysautonomia as they get their first periods, or they start their periods in adolescence and they're starting to become more regulated. So you could certainly see those as separate issues, but most of the time in my patients, it's not so isolated. There isn't just, I have blood pressure issues, I got COVID, and that's my only chief concern.
Yeah, right.
How very often rare. Does that happen? I would say very rarely. Yeah. Is that what you see? Do you find the same thing?
No, I find that if I start asking, like they might not tell me that they've had these weird kind of recurrent episodes of hives, for example. But once I start asking, they're like, oh yeah, I do. Or no, I like my exercise, I really can't tolerate the level of exercise that I used to have, or, things like that.
Or I have gut issues, or my menstrual period's irregular, or have food intolerance, and they don't put the pieces together. But if you, and that's the thing I think that happens with most patients is they might see a clinician that's treating POTS, like maybe a POTS literate cardiologist, for example, and they're treating just the POTS, but the cardiologist maybe hasn't asked the questions like, okay, what other symptoms do you have? And could we relate this to another issue? And I think that can be sometimes where patients are getting lost in the mix, is they just don't have the providers that have the knowledge to understand the different issues and putting them together. So that's probably a big part of it too.
Yeah, which circles back to something that we have talked about a couple of times, which is kind of that like big picture, and unfortunately conventional medicine being kind of in these separate blocks. Every specialist stays in their lane, and they do not go outside.
I want to summarize this for, again, the non-medical people here, because you guys use a lot of fancy language.
We're trying. We're trying not to. I'm trying not to.
So because I've sat in on these conversations. So it's essentially like dysautonomia essentially means dysregulation of your autonomic nervous system, which your autonomic nervous system then controls things like your breathing, your heart rate, your digestion, things that you don't consciously control. Okay.
Perfect. Yeah, exactly.
People get dysautonomia, dysregulation of the autonomic nervous system. Then they start having POT symptoms. They start having they can start having POT MCAS symptoms. And the problem is conventional doctors are then treating those acute symptoms inside of their specialty, and they're not uncovering the dysregulation of the autonomic nervous system. Is that correct?
That's very And one thing that's important to note, to expand on that a little bit, Cole, is these types of patients can have the definition of some of this like triad is multi-system. So it could be head to toe, any organ system, any really symptom at all, skin, gut, menstruation, liver, kidneys, anything in the body could go dysfunctional. And the healthcare system as it's set up is all of those conditions have a separate specialist. So if you're seeing, and some of my patients have 50 doctors for every symptom that is a manifestation of this triad, you've got a list of 50 people that you're seeing to try to manage this essentially potentially one condition. So it can become very, very difficult for people to manage.
Yeah. I've seen this scenario play out multiple times, is that somebody starts having tachycardia or a rapid heart rate, and it's it's disconcerting, it's alarming, and so the primary care refers them to, maybe does a Holter monitor, and then maybe sends them to cardiology, and pretty much, yes, you have tachycardia, but there's nothing else that's determined, and the patient is reassured that there's nothing wrong with their heart, but that's kind of the end of the road.
Yeah.
And they still are, they're still having the symptoms. As you mentioned, they're probably having a multitude of other symptoms, but nobody's tied those in. And that's kind of it. And so, as opposed to, again, looking, outside of the cardiovascular system, looking at the autonomic nervous system, et cetera.
Yeah. And one thing that and we can talk about this maybe a little bit more when we kind of put this all together in terms of actionable treatment or things, we're not going to make treatment recommendations, but things that are done is these patients with these multi-system issues that then extend beyond, say, like MCAS, is like POTS and EDS symptoms, is their laundry list of medications just gets longer and longer, because from a POTS perspective, if they're seeing, say, a cardiologist or, someone that would manage POTS to try to manage it, it could be, beta blockers and other types of medications that are changing the heart rate. It could be, GI medications to change the motility or how fast or slow the gut moves. So these patients wind up on 15, 20 medications that are all trying to tackle one of their symptoms. And because that's not the root cause, none of these treatments are working. They might be helping a little bit, maybe with like some symptom management, but it's certainly not an answer. And that's the really sad part. Is the laundry list of medications that people come to us on with these complex conditions. I'm sure you see that all the time, Dr. Rose.
Oh, yeah, absolutely. I do want to tie in a little bit more into like the hypermobility piece, because I think we've talked now a little bit more about dysautonomia and MCAS. Yeah. So I think we should kind of talk about that. I know, I hear what you're saying. They're all kind of at the root. It's kind of all a similar thing. But I have people coming in and they say, I have EDS. Yeah. And do you feel like, and most of those people have not had like the genetic test, but they, they fit clinically, they fit the picture. They have the gut stuff, they have the connective tissue symptoms. And do you think that there's a negative to them identifying with that specific diagnosis? Do you think there's anything? I mean,
kind of. It sort of goes back to, and this would actually be a great topic for another podcast, is how people use and identify their diagnoses almost as like how they identify as a person. Like, hi, my name is Colin, I have EDS, is like, this is almost like your suit of armor. Yeah. And there's a whole psychology around that. But one of the issues with calling everything EDS is EDS, if a patient has hypermobility, it may not be to the severity of someone with EDS. And I often see that when other issues are addressed, such as regulating, and that's why I think MCAS is at the root, because I've had many patients where I get their MCAS better and they're not as hypermobile anymore. And their pain level goes down. Pain level goes down, and their flexibility is improved, and they can work out a little bit more, and they can tolerate exercise. And their orthopedists and the musculoskeletal specialists are like, "How are you not as flexible anymore? We don't understand. How did you like tighten up? We don't under." It's like, well, we reduced inflammation. That's how. So when people start to self-identify as EDS, it becomes this end game, like, I cannot be fixed kind of thing. This is a genetic thing. This is my genetics. I have this hypermobility, syndrome, and it's the way I am. Well, sure. But, and this goes back to like the psychology of complex chronic illness. It's like, well, if I told you if we could improve your inflammatory response in your body overall, that your hypermobility would improve. What do you say to that? And sometimes people don't believe me until I have to prove it to them.
Right.
So when you pigeonhole yourself like, oh, I have EDS, I have no hope. That's not entirely true. So I like to try to educate people on like hypermobility syndromes, or just hypermobility as a symptom of a more complex scenario, rather than the EDS. Yeah.
Yeah, I think probably in most cases that's in the long term not going to serve that individual with that. Yeah.
Correct. Yeah.
Wait, real quick, I think we missed, that was great right there, but we kind of skipped something. How is inflammation related to EDS? Like, how does reducing inflammation then all of a sudden,
Good point. So inflammation in the body can make tendons, ligaments, joint capsules, muscle, all the soft tissues that say surround a joint, say like your elbow or your knee, that hold it together, right? If you have hypermobility, you can sort of bend your joints beyond their what we call the physiological range. So these are people that can dislocate their shoulder very easily and put it right back in. These are people that can hyperextend their arm or their knee very easily. So when there's inflammation in the body, it can cause a temporary breakdown of these tissues, leading to the tissues not being as strong, in a sense, causing them to be more flexible. You reduce inflammation, things tighten up again.
In a good way.
In a good way, right? To be more, I don't want to say normal. Normal's not a great term, but to be more...
well, stronger. It's a stronger joint.
Right. Yeah. To be in the more physiological space of an appropriate joint function.
Right. So now for the question that everyone's wondering, like, how do you decrease inflammation? Like, what are your strategies for both of you guys? How do you decrease inflammation?
Well, we're not just talking about inflammation, but we're talking about inflammation secondary to mast cell activation issues, or chronic systemic multi-system inflammation. That's a hard question to answer. We sort of addressed that on our last podcast with some things about MCAS, but really is identifying, and we can talk about this, Dr. Rose, if you want, is sort of like where, things like Lyme, where things like mold and viral illnesses and toxin exposure lead to chronic inflammation of the mast cell, leading to hypermobility, leading to POTS. Yeah. So
right.
we did talk about this a little bit. Yeah. We talked about
it's kind of like that.
It's
like that. Right. It's like that load. It's like an inflammatory load, right? So somebody maybe, had mold exposure, had a tick-borne illness, got COVID. It was just like, and then the mast cells it's kind of difficult to control. But yes, I think broad strokes, we have nutrition is a great place to start, gearing the way somebody eats towards a lower inflammatory way of eating.
Or low histamine diet. We talked about that a little bit. We
talked about a low histamine diet and taking certain things that can kind of break down the histamine in food when you're not sure what the histamine content is.
Right. Yep. And then, there's medication options. There's treating these underlying issues. There's the use of GLP-1s in MCAS and complex illness. There's anti-inflammatories. There's anti-inflammatory herbs, antihistamines, low-dose naltrexone, all kinds of things that could be prescriptive. But as Dr. Rose is really pointing out, we have to understand the inflammatory response, and it's not just necessarily medicating people.
Gotcha. What about, I know everyone or most people in the audience are probably wondering, because they hear a lot about GLP-1s. A lot of people are like anti-GLP-1s. Some people are very pro-GLP-1s. How do GLP-1s reduce inflammation? Because that's something I hear a lot is, because that's a huge benefit, right?
Yeah. So some of the research is really on tirzepatide, which is the second generation GLP-1, versus Ozempic, which is semaglutide, the first generation. And tirzepatide, specifically from an MCAS perspective, can target the mast cells directly. So the mast cell is this immune cell, it's a white blood cell that releases inflammatory chemicals. if you target the mast cell specifically, it will stop releasing these inflammatory chemicals. So it can be anti-inflammatory in that sense. And then there's also some studies that show it targets some of the inflammatory cascade molecules, or down regulates the production of inflammatory cells in the body. So it has a lot of promise for MCAS, for POTS, for EDS. And I have had patients that we use something like a GLP-1 at a low dose, and their POTS symptoms dramatically improve. You know, they're patients that couldn't get out of bed, or they have to be, you know, laying down, because if they stand up, their symptoms get too, they're like gonna faint or something. Their blood pressure is too irregular. But the GLP-1 has targeted this inflammatory response in the body, which has then regulated their autonomic nervous system, which has calmed down their POTS symptoms. So it's like a kind of cascade. Yeah. So that's what I've seen with GLP-1s. But there's a lot of other easier things, you know, hydration, electrolytes. I mean, there's a lot of other things. We talk about POTS. And EDS also too, from a management perspective, there's some really great EDS focused therapists and other health practitioners in the world, EDS specialists for physical therapy, occupational therapy. These are people that can teach patients how to move their body in the right way and how to strengthen without hurting themselves. So it is definitely a team effort to address comorbid issues with these patients, for sure.
Yeah, I just want to speak to that as well. I think that it's really, I think physical therapy can be fabulous, but you need to find somebody who knows what they're doing, because it's not, I mean, it's expert training. It's actually being seasoned, you know, with other people with hypermobility, because it's worth looking specifically for somebody. So, yeah.
And that can be hard to find.
It can be hard to find. Maybe especially around here, but yeah.
Yeah, just like a MCAS or POTS literate healthcare provider, you know, or a cardiologist, or because these patients do need specialty care, right? It can, something like EDS can affect their blood vessels. It can affect the heart tissue. Yeah. So these are patients that really need really specialty evaluation by a literate cardiologist, so we can understand if their heart muscle is not affected, right? If they're having laxity, is there enlargement, is there blood vessel issues? So there's definitely a delicate balance that people need to come to in terms of management, and it is not easy sometimes. But understanding where some of these things come from is really important, because then it can guide care better.
I do want to be clear too that, like, I think I feel the same way. Like, obviously, if somebody is having a rapid heart rate, if they're having kind of unexplained any symptoms like that, they should go to their primary care. They should go to the cardiologist. They should get the full workup. Like, I don't think we're, you know, I mean, in no way are we saying it's not worth it. It's not. Don't worry about it. Like, do the workup, get the information, and then you'll know, right?
Yeah, it's a really good point. Yeah. Yeah. And sometimes these patients are frequent flyers in the emergency room, sadly, because they might be in an episode of really severe, you know, pulse dysregulation, or they're fainting, or their pulse is too low and their blood pressure is too low, and they need emergency care. And you can't get around that, right? You need it. But oftentimes it's just stabilizing the person, and then they get sent home. But these are where, you know, we can try to understand the flares better, what's causing it, what's driving the illness to flare, what's driving the severity. Because we can talk about this separately too, Dr. Rose, but what are some of the like hidden factors that may be blocking people's progress, right? I think that's really important, is something we need to address. Like these patients with MCAS, POTS, EDS, you know, if they're trying to do everything right, quote unquote, and they're not getting better, why is that happening?
What's the obstacle, right?
What's the obstacle? So, I know we can certainly talk about that at some point. I don't know if you have thoughts about that, but I think that's an important piece too.
Yeah, I mean, it can be, I know, again, at the last podcast, we talked about mold, like if the person is, you know, not just has a previous mold exposure, but there's kind of an unknown current mold exposure. If there's heavy metals, like this person's going to have a pretty hard time detoxing. And yeah, so are there other things that are kind of in in the way. Again, trauma, unresolved trauma. I mean, we are talking about the nervous system.
Yep. Yeah, we had a Cole and I had a whole separate podcast on that, and
that's
it was, it's worth a listen, because a lot of these patients, and I actually had a patient that dealt with this today, that I just met, and there was a hugely traumatic event over a long period of time that this patient dealt with that really spearheaded years and decades of dysfunction and chronic illness, to the point where there was, medical disability, inability to work. And I'm certainly not saying that that was the only thing, but it is a huge part of it. Yeah. Huge part of it. Yeah, for sure. Lyme disease, viruses, all kinds of things. So
you
understanding the full picture is important.
Absolutely. You mentioned like menarche when a girl first gets her period, but I feel like it's most hormonal transitions. So perimenopause, menopause, right? That can be it's like everything's kind of kept under wraps, everything's fine, everything's controlled, and then it's suddenly not, right? Like that's just enough to be the tip of the iceberg.
That's a huge issue for most of my female patients that have these complex conditions. Every time there's some sort of hormonal shift. So this is to your point earlier, is you have to ask questions. You have to take a full history. Tell me about when you were young. Tell me about when you were a child. Tell me about your first period. Tell me about adolescent years. So these women can be struggling with symptoms that are all over the place, like their first period. You mentioned menarche, or their very first period, is the medical term for that. And they have symptoms. Then every month when they get their period, they have symptoms. And then when they get pregnant, they get symptoms. And then post-pregnancy, they get symptoms. And then perimenopause, menopause. So it's like the hormones are so important for the body, but in some women's case, it backfires.
Right.
So,
Right. So that's right. So for some women, kind of addressing that piece of it as part of the treatment plan of optimizing hormones, years before menopause, as we know, perimenopause can start in your mid-30s. So,
So we're approaching the halfway mark here. So thank you everyone for joining. We appreciate you guys. A lot of action in the comments. Keep it up. Let's transition. Like, what is your approach for actually figuring this out? Like, what is your framework through when you see a new patient, for someone who has EDS or MCAS or dysautonomia? Like, what are you going through? So you mentioned like the trauma piece of things, but okay, you've got all this information. Like, how do you start to actually get this person's inflammation down, get their autonomic nervous system back regulated and balanced? Like, how do you actually go about doing that? Because once you balance, you get inflammation down, the autonomic nervous system is, regulated again, these symptoms should start going away, right?
They improve. It's not going to be overnight, but Dr. Renaud,
certainly not overnight. So not overnight is the key phrase there. This is complex multi-system layers that you have to peel away kind of one at a time. And in all honesty, there can be a lot of bumps along the road of, okay, we try a treatment and the patient doesn't tolerate it, or it makes the symptoms worse, or, we have to understand, what to do from our skill level, right? I'm not a therapist, right? I'm not a trauma therapist. I'm not an occupational therapist. I'm not a physical therapist. So there's a lot of things that have to play into what the patient really needs. And the way I try to do this, from my approach, is really two things. It's starting with some foundational support. And that's just the basic sort of tenet of, say, a functional medicine approach, right? What can we start to improve with this patient foundationally? Dr. Rose mentioned earlier some like nutritional changes. Is there deficiencies that we can start to work on that's affecting their immune system? Can we bring light to some of these issues, right? We talk about trauma. We talk about stress. We talk about situations in the patient's life that may have exacerbated this. And that can be very healing for someone when they start to realize, oh, wow, my sexual abuse, my a relationship that I was in that was emotionally abusive, my car accident, my concussion, I started feeling really bad after that. So that can be, and we might not have an answer right away. We might not ever have an answer, but that is very illuminating for patients. So there's building foundation. There's recognizing other issues that are going on, right? Has there been a mold exposure? Could they have Lyme? Could they have other type of infections going on? And then it's really trying to symptom manage, right? How can we, in the short term, one of my short-term goals for all my patients that fall into these categories is identify some of the long-term things that we need to work on, but then also what can we do in the next 6 to 12 weeks to get your symptoms improved, right? Get you functioning a little bit better. Are you not working right now? Are you having trouble caring for your household, your children, your day-to-day activity? What can we do to really get that improved? And those are like my 3 prongs. That's my approach. Foundational support, comorbid issues, that's really long-term. And what can we do in the next few months to start improving? Yeah. What do you think, Dr. Rose?
Yeah,
that's
how I do the same thing. I feel like the way I talk to people about it is that I'm a believer in doing things in parallel. Like I feel like we can do the root cause work. We can keep digging. We can keep kind of, again, peeling away the layers, but that doesn't mean that we can't try some things to help you in the short term. Symptom management, like there's nothing wrong with that. And and it's not one or the other. We don't have to wait for one to do the other, and we can do them together. I do think that with people with mast cell activation syndrome, they have sensitive systems. And so we have to be, these are the people that I'm not going to recommend starting 3 nutraceutical supplements at the same time. We're going to start 1 nutraceutical supplement at a very low dose, and we're going to see how they do, right? And or even or anything really. It's like low, really low, really slow, and usually that ends up being more. They feel better in the long run than if we throw too many things. Because all of them might be great ideas in theory, but not for this individual at this time.
Yeah, and that I always have that as like a disclosure with my appointments, my new patients who are struggling in this way. It's like, I hear you, I see you, I understand you. So I validate what you're going through. But my disclaimer is this is not going to be in the next week. This is not going to be 2 weeks. This might be 6 months. This might be 2 years. And it's really about setting the expectation and educating the patients as much as possible, because if they can understand and be educated a lot, I think that's what a lot of patients are really looking for.
Absolutely.
They are desperate from some healthcare provider, they don't care who, to say, I hear you, I understand you, I validate what you're going through, but this is not simple. A lot of patients that struggle with these multitude of issues are gaslit, and they are given answers that, well, it's all in your head. This doesn't make sense. We don't believe you. We're going to give you a psych referral. Maybe this is just a woman's issue. Maybe it's your time of the month. Maybe you're anxious. Oh, you just had a baby. Maybe you're just like, I've heard ridiculous things that patients' doctors have told them. So I think a big part of our job, and I know you do this too, is just saying, I hear you and I understand you, and we have a lot to work on, but we can certainly do the work, rather than get out of my office, you're fine, I can't help you.
Here's some Wellbutrin, and
here's some
Wellbutrin. See you in 6
months. Right, exactly. Yeah, and that I think is, we talked so much about trauma, right? We had this separate podcast on trauma, which we did, I think was very illuminating, but this is trauma.
Like health
trauma. Yeah. Most patients in this world are medically traumatized. They've been in the ER 50 times. They've seen 50 specialists. They've been poked and prodded more times than they can count. And they've been told, you're making it up. Here's a psych referral, blah, blah, blah. So every time they don't get validated, it's just another trauma. And it just adds to the trauma bucket, if you will. So that I think is huge. we haven't necessarily given them anything, right? They're not going home with a medication
No,
or a supplement.
we've just treated them with respect and dignity.
But exactly. That's a huge part of this. And I think that's a huge part of what healthcare is missing. But, you know, it's a really important piece of it for sure. Yeah.
I think it does circle back a little bit to why sometimes people do latch on to a diagnosis to,
yes,
you know, whether it's POTS, if they don't actually have POTS, or EDS when they don't really have the genetic version, right. Because it's validating, right? I mean, they go online and they've read the list of symptoms and they say, that's it, right? And it's like something I mean, it makes total sense. Like it's something that they can hold on to. I think it's maybe for the first time for them, it's been validating. And so then to come to a provider who is educated in it and has seen other cases similar and is not, like you said, gaslighting,
right.
Without even the mention of a treatment, that in and itself, I think, is healing.
Very, yeah. It's I think one of the most important takeaways from all of this and from our conversation we had about mast cell issues, and this is most patients. There was a comment in here that patients have to educate their doctors, you know, and how dare you tell me?
Yeah, right. I'm the expert here. Yeah,
right. I'm the expert here. How dare you tell me? And it's like, well, gosh, you know, this is sort of the perfect model of like COVID. We don't know anything about COVID. COVID was brand new. And we sort of exist in the healthcare world like we know everything about everything. That's just so ridiculous and so egotistical, you know. So you can't have a condition that I didn't learn about 20 years ago in my healthcare training. You know, well, COVID's new. Like why can't we have new things? Why can't things evolve? Why can't things become more complex? And I just don't think people have the brain power, maybe, or their egos are too strong for questioning things. So it's all part of gaslighting, and it's all part of trauma. So it's tough. Yeah.
But
that's why we do the work we do.
Yeah, a lot of people in the comments are agreeing with you guys. I don't know if you can read them, but great work.
Yeah, hi to everybody. Thanks for your comments. We see them.
So I guess I think one of the reasons a lot of people are here, we had, again, over 100 people register for this, is they want to understand like the tangible ways that we can actually help people get better with functional medicine. So with the last 18 minutes here, and then if we open 5 minutes for Q&A, we don't have a ton of time left. Could we get into like some of the actual strategies you guys use, some of like the tests that you're doing and what these tests are uncovering, and then some of the tools that that patients might not be familiar with, I think would be really helpful.
Yeah. Do you want to start, Dr. Rose?
Well, I'll just start. I mean, I think some of the testing is what every new patient gets at MedMatrix. And so at that first visit, we can look at hormone levels, we can look at inflammatory markers, which are really important. We can look at micronutrient deficiencies. So as was mentioned earlier, if somebody has a vitamin D deficiency, that's not helping any of this. It's not helping connective tissue, muscular health. It's not helping inflammation. It's like, so that's kind of like a low-hanging fruit, right? Is like making sure that they don't have iron deficiency, anemia. Any of that is, again, maybe not the cause of any of these issues, but it's really not helping. So right off the bat, we have information that we can address, right? And then I think we talked a little bit about it with the mast cell conversation, but are there other tests, Dr. Renaud, that you're going to order if you're suspecting, and what are those?
Sometimes. I think it really depends on the patient and their level of complexity, or even just financial means. I hate to say that, but
it's a reality. Yeah,
it's a reality. If patients are uninsured, right? Am I going to try to order a battery of tests for mast cell issues that may or may not be positive? Probably not.
And you can see it clinically. It's pretty obvious to you clinically already.
Right. It is pretty obvious clinically. And I think one of the ways that, I sort of look at this too, and from even the way I chart on patients is I can write stuff down and say, my suspicion for XYZ is here because of da 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 da. And, we could trial certain treatments because they are of low risk, right? Over the counter or certain supplementation, or we'll start addressing certain dietary or nutraceutical needs that they may be deficient in. So you could certainly give patients a place to start and try to start helping without maybe $10,000 worth of advanced testing that may or may not give us more of an answer, right? Because we have to be realistic with patients' expectations. These are patients that have probably seen 50 people before they've seen me, maybe.
They're ready to kind of get started, right?
They're ready to just go. Exactly. Yeah. So when we talk about like risk and potential benefit, trying some certain things, whether they're over the counter or really, really low risk, like a medication or a nutraceutical, what's the harm in that, right? If we can sort of back it up clinically and say, my suspicion's really high based on A, B, C, D, E, F, G, we're going to try this very low risk approach. That's very, very simple to do. But it's really having that knowledge to do it is the most important piece. Yeah. And we could be talking about dietary changes, right? We talked about the low histamine diet. We could be talking about low salicylate diet. We could be talking about, maybe we should do food sensitivity testing. Maybe we should, do some more micronutrient testing if they have low vitamin D, if they have low B12. You mentioned iron. I mean, these are all very simple things that can be starting as part of our like actionable things now as foundational pieces. And then we can certainly, from like what I do with patients, is say, okay, how can I wrap my head around them as a whole person and say, okay, what's the biggest dysfunction they have? And can I find something in my toolbox to help them function better over the next couple of months while we address other things? Do they need Lyme testing? Do they need mold testing? Do they need viral testing? We can do all of that. And I do, and you do too, but that takes 2 months, right? Or something. And that could take 6 months to get better. So I'm trying to find actionable things that we can do right now. And a lot of our initial testing that we do as part of our new patient panels gives us a lot of actionable items, even if the patient has, heart disease or low hormone function or, whatever the case is. There's a lot of actionable things we do right away. So.
Right. And I would say even including like having somebody come in for IV treatment, right? They can come in and they can get some glutathione, which is anti-inflammatory. They can get kind of an, amino acid blend, a vitamin blend, and relax for, 30 to 40 minutes while they're getting the IV. That's like a very short-term way to feel better.
One of the best beneficial treatments I ever gave to a POTS patient was, you look really dehydrated, and POTS is not necessarily a hydration problem, but that's part of it. And when you address dehydration, it's like, why don't we just hook you up to some IV fluid? We don't have to put anything in it. We'll just keep it simple. And it's like, I'll get a message the next day. I slept really well. My symptoms weren't as bad. Okay. Come in once a week. Come in every week. Come in 3 times a month. Get a bag of fluid, saline. I mean, it can be so simple.
And cheap, right?
Cheap. Exactly. So sometimes it doesn't take a lot. And really that's what we're looking for, is something to just move the needle a little bit, right? To get the ball rolling. Yeah. That's a really great point. I'm glad you brought that up.
Yeah. I mean, maybe they're taking electrolytes at home as well, making sure.
Put stuff in the IV, right? If they're maybe not absorbing, or, you need more, a bag of fluid with some B vitamins or something, or, it doesn't take a lot of effort sometimes to be extremely, to provide extreme, palliative benefit or something that's really beneficial. It doesn't take a lot sometimes, but I think what happens in the medical world is we're trying to be so complicated with our thought process. Like, how do we solve this really complex problem? It's like, well, just bring it down to the basics for a second. What are we missing at the basic? Let's try some basic stuff and see if that helps. And it really does. Yeah.
Yep. Well, and like just the foundational lifestyle pieces, like, are you sleeping? And if not, can we, what can we do to help you sleep better? I can't do a podcast without talking about the benefits of having a daily bowel movement. So are you
No, you can't.
Are you being regular? Are your bowel movements regular? What's your stress management?
Here, Dr. Rose, if you want to do that, you got to give context every time. You can't just
I can't just throw that out.
Yeah,
well, I'm famous
she's
around
a big
here
fan of bowel movements. Let's just say
regularity. Yeah, I feel like if somebody's constipated, that if you ignore that, then you're going to have a hard time with success with any treatments. I think that it's just the body's best way to eliminate, whether we're talking about hormonal metabolites, medications, even supplements,
toxins.
like things that toxins, everything that kind of needs to leave the body through the stool is the most efficient. And so if that's not working, it's just going to be, you're just making everything is just harder to get better, and all the other systems aren't going to work as well. So whatever, we have a lot of tools in our toolbox to optimize that.
Yeah. I don't know how many times in my career I've heard like, maybe once a week I go, and I'm like, oh gosh, and I can't even imagine how uncomfortable that must be, number one. Right. But then, as you said, from a physiologic perspective, you're not getting rid of toxin, you're not getting rid of metabolites from the regular body's processes. Yep. Really, really difficult to improve someone's function. Yeah. And that could be related to dysautonomia and POTS
right.
and
it could be
EDS, right?
Dysmotility, right?
Dysmotility, which is dysfunction of the gut, the autonomics of your gut digestion. You don't control that, right? You don't control how you digest your food. It just happens. So if it's not working well, that makes you constipated. And then when you're constipated, you're making, so it goes around in circles. So you bring up such a great point. It's like we have to just regulate some of these basic functions to get the body in some sort of balance. Yeah. We have to try. That's like the very root of, okay, first day, what do we do to regulate the body? That's really, how we have to approach it. Yeah.
So we got 9 minutes here. So I'll let both of you guys go through one patient case that you've helped treat with dysautonomia, and then we'll open up to Q&A at the end. So Dr. Renaud, why don't you go first? Why don't you share a case with a complex patient dealing with these things who came in and the whole picture?
I had a patient, this was maybe 2 or 3 years ago. Her dysautonomia was so bad that when she changed positions of her body, like sitting in a chair, reclining back too fast, she went into anaphylaxis. Anaphylaxis is a medical emergency of an allergic reaction where you could die. Your throat could close and you could lose your ability to breathe. She was so unstable from her nervous system and her autonomic nervous system that if she changed her body position too rapidly, she would go into this anaphylactic state. And it happened while I was with her. I witnessed it.
Wow.
And I had to administer 6 EpiPens to get her functional.
Oh, that's scary.
Obviously, we had to call EMS and, whatever. But this was just normal for her. And it's like, holy crap. It was very scary when I saw it actually happening. So one of the biggest issues that I tried to overcome was, how can I just regulate this person? And it was the IV fluids, like I was mentioning earlier.
Yeah.
It was, and I was able to get her home health IV fluids.
Oh, nice.
Yeah. So it was really easy to just have someone come, and she would have home health come twice a week, do IV fluids, and it really started to stabilize her a lot. So what was that? I don't know, right? Is it a fluid issue? Is it baroreceptors in the vessels? I don't know. So yeah, it was quite remarkable.
What happened from there?
What happened from there? The patient lost touch because she had to move away.
Oh man!
So I was not able to care for her anymore. She was too far away from where I was treating her. So I'm not sure. Actually, I don't know.
Well, that's interesting. Yeah, good story. Yeah. I mean, hopefully she's still getting the help. But
yeah, I hope so. But it was one of the most severe, complex, scary cases I've ever treated in my career. Really, really crazy. Yeah.
Yeah, well, right in front of you. All right, guys,
Yeah.
if you want to start throwing some comments or questions that we can answer, again, we can't answer specific questions to your health. I mean, we can't give medical advice, but we can answer broadly. So, yeah, drop some questions. We'd love to answer them for you guys. And then while we're waiting for questions to roll in, Dr. Rose, why don't you share a patient case study that you saw?
Yeah, this was a young man. I think he was I'm going to say late 20s that I saw a couple of years ago. And he had been fully functioning. He was, living in a different city from his parents, and he was working. And this must have been early COVID, because he, again, fully functioning, was like very active at the gym, like worked out a lot. And he got COVID. And the first thing that came up for him after COVID, he seemingly got better from COVID, was unexplained anxiety. And it was anxiety and the rapid heart rate. And it was really hard for him to determine what came first. Was he anxious and then his heart rate went up, or did he get the rapid heart rate, which then was confusing and spiked anxiety? So that was going on. And then his fatigue, it was like, it was almost debilitating. He had to quit his job. He had to move back home to live with his parents. And he really couldn't exercise. And that had been his, physical health, mental health, like that was his thing. And so when he came in with his mother to see me, he was depressed, right? He was like, his life had kind of been taken away from him. And, had seen had done the cardiac workup, and everything was fine from that perspective. Nobody really knew what was going on. So I suspected POTS, and it was really kind of slow and simple, right? Like, I worked with him to start to do an exercise program that was so modified compared to his previous, but it was something, right? It was like very gentle. Maybe it was like walking for 5 minutes. Maybe it was, very gentle yoga, something he would have done before, but it was something. We did a lot with hydration. We did a lot with compression clothing. So not just socks, but kind of like full leggings. And then some various nutraceutical supplements that were really geared towards the autonomic nervous system. So there were some vitamins, there were some minerals, and nothing fancy, but it was enough that he was like very gradually able to kind of regain his life. And my theory is that it was really the COVID infection that was kind of that final piece for him. And so just kind of rehabbing him enough to backward to where he could function.
That's the key word. It's rehabbing. That's what I try to educate patients on. It's like, this is rehab, right? You see some of these videos online, like that go viral, of like someone's in a car accident and they lose their ability to walk and blah, blah, blah. And you see their progression over the years and regaining muscle strength. That's what we have to do with these patients. It's rehab. You're going through a rehab process. And that's sometimes hard for people to understand.
Right. Because we think really of rehab as a physical thing only. Right. But it's not. Yeah.
It's not. Yeah. Well, it's physical, but it's not. It's not like
it's a lot. Right. A lot of other things too.
It's a lot of other things. Yeah. Sure.
All right, guys. So let's roll into some comments here. So first comment, great question here. I just discovered you guys recently. Would you briefly talk about the difference between what you do versus a primary care doctor, for example?
In general, not just for this, but just in general.
Yeah.
In general.
Kind of what they're getting at. Yeah.
Yeah.
So we are not, I like to make it clear that we are not primary care. Primary care, I think those providers are really useful for kind of triaging, right? So kind of for, they're your go-to person, right? So they're your go-to person. So you can then get your mammogram, and you can, if you need to get kind of all those screening tests, they're great. Kind of for keeping like the big picture in mind for you. They're not going to spend the 60 minutes with you, the kind of the in-depth, the blood work that you're going to get from them is not what we do. And the amount of time that we spend going through that blood work and explaining it in the context of your health that's kind of what, you're not going to get that at primary care. I mean, we could go on and on about kind of what we offer with functional medicine. What do you want to add to that, Dr. Renaud?
I think one of the major differences between us and primary care is, at least for me, and I will speak for you, I know you do the same thing, is a big thing in primary care, as you said, is sort of like gearing them towards another thing, right? It's like, oh, you have diabetes, you're gonna go see the endocrinologist. Yep. Oh, you're having menopausal symptoms, go see your gynecologist. Oh, you're doing this, you're doing that, so go see the specialist. What we try to do is we're not specialists, right? I'm not a gynecologist, I'm not a primary care doctor, I'm not, we don't have specialties, but what we're trying to do is take all these things and not hand it off to someone else, but say, well, how can we help you optimize your health with all these things that you have? How can we look at this as a whole person approach rather than have 5 different people or more manage you? That might be necessary. I'm not saying people don't need specialists. They do 100%. But what we're trying to do is not necessarily pass the buck off to everybody else and try to understand how to make the person's function better. Where we're talking about dietary things, we're talking about lifestyle, we're talking about genetics, we're talking about the gut, we're talking about hormones, we're talking about, the list goes on and on. So, yeah.
Well, and how it's all tied together. And so,
right.
Yeah.
Good point. Yep. How it's all tied together. Yep.
And Dr. Rose, you talk a lot about this too. The toolbox is much bigger, right? A lot
exactly. More. I feel so blessed that we have such a large toolbox. And I think that in conventional medicine and most conventional primary care practices, it's not anybody's individual's fault. It's just that they just haven't been trained. They just literally don't have the toolbox. And it's just such a rewarding part of this medicine is that we do, again, whether it's nutrition, whether it's peptides, whether it's some hormonal support, and we can really I think it's very personalized because of that.
And I want to also too say that we've been trained to do this.
Yes. We're not just making this
like
stuff up.
We're making it up. So, we have been trained in different specialties, different subspecialties, different postgraduate, work in different things, so we can tie this together. So yeah, we do have the ability to do certain things, but we also don't have the ability to do certain things.
Yeah. I've just we
can't do everything. When my patients need to see a GI doctor, they need to see a GI doctor because I'm not one, right? So we can't heal everything, but we can certainly start putting pieces together and start optimizing and building back the health that has been lost. But it is a team effort, which is in connection with their other doctors, 100%.
Yeah.
Okay.
Yeah.
Great, guys. All right. We got you guys down to hang around for another couple minutes, answer some questions. I don't know if you guys we're at an hour here.
Sure. I probably got 5 minutes.
Yeah, we can take another question or so. Yeah.
All right, we're gonna answer questions at the end here, guys. Hey, real quick for people who are hanging around, there is actually a limited special going on for people who joined us today. I just commented in the YouTube comments. It's the live special.medmatrixusa.com/webinar. If you click that, you can actually get $200 off as a new patient. I only think it's available for another hour. So this is a one-time thing. So if you're here watching this and you're interested in becoming a patient, set up your free discovery call with that right now. It's right in the comments. Answer some of the questions really quickly. Do you take insurance? No. Do you see 17-year-olds? No, you need to be 18. Correct, guys?
Yes.
Yep, correct. How often, do you do telehealth? Yes, we totally offer telehealth. You do have to be in Maine or New Hampshire. Here's a good one. How often do you see patients? How often do you want to see patients?
I think it depends on the individual and what their needs are and how kind of acute the symptoms are.
Ooh.
We can still hear you.
Sorry, I don't know what happened. Let me change my camera. Sorry,
I think your camera died, Colin. Just switch to your
I don't know.
Computer camera.
There
we go. Nice.
That's weird. It's still on. I don't know. That's weird. Sorry.
I think it depends on the individual. It depends on, say, we see them and there's, certain tests that we want to look at or repeat. Mm-hmm. Maybe we wanted to, for some that might be in 6 weeks. Usually for me, once I have somebody on some kind of protocol, it's usually about every 3 month kind of pattern, where we'll do repeat blood work in about 10 weeks and I see them in 12, and we're very available in between, right? So we're very available for questions. I really encourage people, if things change for them, if they get imaging somewhere, if they did go to a specialist and I had a woman today who had an MRI results, and she had uploaded those into her portal before I saw her, which was super helpful. So just knowing, people should just know that, even time between the visits, we try to be very responsive.
Yeah. And we have the ability to, we have sort of schedules that we can allow for another appointment if needed. If people are having an issue or they want to start something, or you don't have to wait 6 months to see us. That's another positive.
Okay, great. A lot of questions here. So where does someone go, or what type of specialist, to determine which of these diagnoses after hypermobility syndrome has been determined? Or is that what MedMatrix does? So I guess to simplify this question, can you guys diagnose someone with MCAS, hypermobility, EDS? Or should they then go to specialists first? What's like someone who thinks they have these issues, like where should MedMatrix and you guys fit into this?
I think diagnosis is the word that we need to focus on. So what does that mean, right? If you listen back to what Dr. Rose and I were talking about earlier in the podcast, is we were talking about clinical assumption. We were talking about sort of clinical diagnoses that are made based on symptoms. So we can certainly look at a patient and say, I suspect you have this. These are some of the diagnostic tools that we might use, but we might not do them because of cost or inability to do them. So we can proceed with your care based on XYZ. So it's not really that simple of an answer, but certainly if I feel that I need genetic testing, we would have to do that. If I certainly feel that a patient needs to see, somebody for other specific testing that I'm not able to do, that's where we would do that. But the word diagnosis is kind of, we have to take that with a little bit of a grain of salt. Does that answer the question well enough?
Yeah.
I think so. Yeah. Can menopause cause you not to function, dizziness, or?
Yes.
Okay. That was an easy one.
Yes.
Let's see. Let's try to do two more.
There's a question. Do you work with children? Unfortunately, no. You have to be over 18. Yeah, we're not licensed for that.
Let's see. How much does the first visit cost? If you book through the link that was just put in the comments, you would get $200 off the initial intake program, which is normally $1,600. So for you, it would be $1,400, and that covers kind of a full blood workup, covers the time the providers spend preparing for you, and then the full hour appointment. So that's kind of what you're looking at financially. Let's see here.
Maybe that's a good place to end.
Yeah, cool. I think it's a good place to end. All right, guys. I'm gonna.
If you want to be a patient, go to the link.
Yeah, if you're interested in becoming a patient, click the link below. Again, that discount will only be available for probably about another hour. So you can click that, and then set up a call with one of our patient coordinators, and then enroll as a patient. So, all right, everyone, that's it. Guys, any words you want to leave the audience with?
I just want people to feel like there are answers out there, and that I think when you're somebody who's been living with any grouping of this, whatever mix of these symptoms and these conditions, like it can feel isolating, it can feel hopeless. And I just want people to have like a little glimmer of hope.
Yeah. And that really goes for anything. It could be these complex issues, but it could be, you're struggling with something that's totally unrelated and you don't feel heard, you don't feel understood. I say all the time to patients, I don't have a great answer for you right now, but I'm going to work on what we have, and I'm going to try to help you as much as I can. And it's just really about understanding and meeting the patient where they are.
Yeah. Awesome. Thank you, guys. And then, hey, for everyone who's still live, we got a group of you guys. We're doing a webinar with me and Dr. Renaud tomorrow at 2 p.m. Eastern time on arthritis and joint pain. So it's going to be a good one. Super excited for that. I know a lot of patients come to us to get help there. So if you want to watch that, follow us on YouTube, Instagram. We will be going live again on the same platforms. With that said, all right, everyone, thank you so much for joining.
Thanks, Cole.
Thank you.